Hello, everyone, and thank you for joining us this evening for the fifth week of the RISE Institute and Rugby Research and Injury Prevention Group 2026 Analytics Series. Our first intern is Chris, who will be presenting on attributable risk and calculating odds ratio. Chris, could you please share a few details about yourself and share your screen when you're ready?
Hello all, my name is Chris Franchini. I'm a rising senior at Northwestern University studying neuroscience and Spanish on the pre-med track, and today I will be presenting for Analytics Club on understanding relative risk odds ratio in related terms. Starting with the clinical scenario, I would like to start by talking about the design of this trial. This trial is a hypothetical 8-week randomized controlled trial of venlafaxine and placebo in 76 depressed patients. So we can see that 8 people out of the 40 developed sexual dysfunction with venlafaxine as opposed to the placebo, where 3 people out of the 36 developed the sexual dysfunction. These 4 numbers, interestingly enough, are all that is needed to calculate every measure of effect size that follows. Looking into some context of learning absolute risk, we can see that absolute risk is defined as the likelihood that an event occurs in a given population at risk. The calculation is the number of persons who experience the event divided by the total number exposed. In venlafaxine, the trial, we saw that 8 people were affected out of the 40 that in the trial group. This gives us an absolute risk of 20%. On the other hand, the placebo showed 3 out of 36, giving us an absolute risk of 8.3%. More simply, this is about 1 in 5 patients on the venlafaxine and 1 in 12 in the placebo who can develop new onset sexual dysfunction. Looking now to attributable risk, this tells us what percent of the venlafaxine is attributed to the placebo. We see that we can calculate it by taking the absolute risk of venlafaxine minus the absolute risk of the placebo, giving us 11.7%, and then we divide that by the absolute risk of the venlafaxine, which is 20%, giving us a 58.5% risk. So, while these numbers may be confusing, we can now turn this into attributable risk and more simply say of the 20% overall risk with the venlafaxine, we can see that 11.7 percentage points, which translates to 58.5% of cases, are specifically due to the drug and not due to placebo overlap. Now looking at the number needed to harm, this concept is how many patients must be exposed to a risk factor before one extra case of harm occurs. Connecting this to rugby, this can be how many concussions must we see before we get one extra case, how many injuries must occur before we get one extra concussion, one extra case of this attributable risk. So the calculation for the number needed to harm is 1 divided by the attributable risk. For example, in this case, we can see that the attributable risk was 11.7, as we just saw in the previous slide, and the number needed to harm was calculated to be about 8.5 rounded up to 9. This means for every 9 patients treated with venlafaxine instead of placebo, we can expect 1 extra case of sexual dysfunction. Now, turning to relative risk, this concept is the likelihood of an event after exposure compared with the likelihood in a control group. The calculation can be the absolute risk in the exposed group, venlafaxine in this case, divided by the absolute risk in the control group, which is the placebo. We see that when we divide the absolute risks, we get a value of 2.4. This value being greater than 1 means there's an increased risk of sexual dysfunction with the venlafaxine treatment as seen in this graph. If it were less than 1, we would say that there's a decreased risk of sexual dysfunction as compared to the placebo. Looking to the odds ratio, odds is a little bit different than risk, as odds are used to compare occurrence to non-occurrence. So say I roll a 6-sided die and I want to roll a 5. There's one side for 5, so occurrence is the 1 over 5 versus the non-occurrence, which is the 5. The odds of rolling a 6 are 1 to 5 versus a risk of 1 in 6. occurrence versus non-occurrence versus happening versus not happening. So the concept of odds ratio is it compares the odds of an event in the exposed group with the odds in the control group. So if we look at the odds of venlafaxine, it is 8 of the cases which were occurred, 8 cases of sexual dysfunction versus 32 cases of non-sexual dysfunction. And the odds of placebo is 3 cases of sexual dysfunction versus the 33 cases no sexual dysfunction. So we can see that the odds ratio is dividing the odds of venlafaxine by the odds of placebo, and we get a 2.75. This, stated more simply, is that the odds of sexual dysfunction with venlafaxine are 2.75 to 1 relative placebo, showing that there is a positive occurrence with venlafaxine and sexual dysfunction. So why absolute risk matters? Low baseline risks, such as sertraline in pregnancy, raise the odds of complications, odds ratio of 5.7, but absolute risk rose from just 0.02 to 0.1, a negligible account. So high baseline risk is a relative risk of 1.2 applied to a 30% baseline risk can raise it to 36%. This 6-point increase is clinically important and significant in treatment. And the rule of thumb is that doubling the risk matters when absolute risk is low, when we have a low baseline threshold, but is serious when absolute risk is high, because as we can see, when absolute risk is high, we can raise by 6 percentage points with a 30% baseline to a 36% with the risk factor, showing that a high baseline risk can attribute to a greater increase in percentage points and a greater increase in attributable risk. So the key clinical takeaways are that absolute risk is the probability of an event, whereas relative risk compares the risk between groups, and odds ratio compares the odds between groups. So with relative risk and odds ratio, 1 means no difference, above 1 means increased risk, as we saw in this venlafaxine case, where we had a 2.4 relative risk or 2.75 odds ratio, showing that with the venlafaxine treatment, there's increased risk of sexual dysfunction. And we can see that if we didn't see it in this case, but if the odds ratio or relative risk were less than 1, it would mean that there'd be a decreased risk. So when we interpret these together, we can see different clinical outcomes that can show us and tell us in clinical settings ways that we can use these drugs to treat patients and side effects that may occur if they're significant or not. So all of these base data points are very important and can connect to rugby, sports, and beyond. Thank you very much for listening. Here are my references.
Thank you, Chris, for that excellent presentation. Does anybody have any questions, or Dr. Lopez, do you have anything to add?
Yes, no, thank you so much, Chris. That was a good talk. The more important thing is just make sure that, with relative risk, there's some complications with that. And that is, the susceptibility of disinformation, exaggerating the effect, the exaggeration of the effect. So make sure that when you're, calculating it, you're making sure that the strength of the association is forward, but make sure that you also be careful, because it could provide disinformation if you don't have appropriate calculations for the strength. That's all. But otherwise, good.
All right. Our second intern is Natalia, who will be presenting on relative risk and interpreting 2x2 tables. Natalia, could you tell us a little bit about yourself and share your screen when you're ready?
Thank you. My name is Natalia. I am a rising senior at Villanova University, and I am going to share my screen now. Please let me know if everyone can see that in full screen. Okay, so relative risk and interpreting 2x2 tables. Okay, what is a 2x2 table? A 2x2 table is a simple way to organize and compare two variables that have two positive outcomes, such as a yes or no, positive or negative, or in the case of sports medicine, injured or not injured. It helps researchers see whether there is a relationship between two variables. One variable is placed across the top of the table, and that represents the columns, and the other variable is placed on the side, which represents the rows. Every participant or observation is classified into one of the four boxes. In the graph on my presentation, the letters A, B, C, and D represent the number of people in each of those four categories. And then the A plus C and B plus D represent the total, which represents all the yeses and all the nos. Interpreting 2x2 tables. When a 2x2 table is created, then you can interpret its meaning. First, you identify what each variable represents, determine which variable is shown as the rows and which one is shown as the columns so you know what each is comparing. Next, you examine each of the four cells. Each cell represents a different combination of the two variables. Depending on the study, these may represent positives, false negatives, and true negatives, or simply just an agreement and disagreement between two measures. Then you review the rows and column totals. These totals provide context by showing how many participants fall into each category and help ensure that the data has been organized correctly. After that, you can calculate and interpret different statistical measures that come from the table. Some are sensitivity, specificity, accuracy, positive prediction value, negative prediction value, and odd ratio. These statistics help determine how well a screening or diagnostic test performs. Finally, you can use all this information to draw overall conclusions, ask whether there is a meaningful relationship between the two variables, and whether the test or intervention is effective enough to be used in practice. So here is an example of a 2x2 table that has been used in sports medicine research. In this study, researchers wanted to determine whether the SIMO Self Screen, which is a smartphone app that allows people to assess their own movement quality, could accurately identify individuals who experience pain during movement. To evaluate the app, 80 participants first completed the SIMO Self Screen and then completed the Functional Movement Screen. The functional movement screen is a series of movements that is done by professionals to identify limitations and imbalances, while the SIMO self-screen is something that the participant did themselves. The rows of the table represent whether participants reported pain on the SIMO self-screen, while the columns represent whether they had pain on the functional movement screen. Looking at this table, you can see that 17 participants reported pain on both of the testing, which meant that the two tests agreed. 14 participants reported pain on the SIMO self-screen, but not the functional movement screen, which means that the two did not agree. 7 participants did not report pain on the SIMO self-screen, but did have pain on the functional movement screen. And then lastly, 42 participants reported no pain on either test, which demonstrates agreement again. The chi-square value of 8.73 and p-value of 0.003 indicate that there is statistical significance between the two variables. Because the p-value is below 0.05, the results suggest that the SIMO self-screen app generally agrees with the functional movement screen. And although there are some disagreements between the two tests, it could be used as a potential way of identifying pain in the future. So, more examples of when a 2x2 table is used. A 2x2 table is generally used to compare two variables that are yes or no, or have two options. It's useful to evaluate diagnostic tests and compare proportions between two groups. It helps measure association between risk factors and outcomes and allows for a lot of statistical information. When it comes to sports medicine, some examples are movement screening, injury prediction, concussion assessments, treatment outcomes, and once again, diagnostic tests. For the strengths of 2x2 tables, one of its major strengths is that it's very simple and easy to interpret. It clearly organizes data, making comparisons between two groups or tests very straightforward. It also allows researchers to evaluate diagnostic accuracy by calculating measures like sensitivity, specificity, accuracy, and predictive values. Lastly, it supports statistical testing such as chi-squared and odd ratios to determine whether the relationship between the two variables is statistically significant. For the relative risks of 2x2 tables, it only works with variables with two categories. So if you are trying to find something that is more complicated, you would not be able to use a 2x2 table. It can also oversimplify data by reducing information into just two categories when there could be a greater range. The accuracy of the results depends on correctly classifying participants and using the appropriate statistical analysis. Errors in this can lead to incorrect conclusions being drawn. Another limitation is the small sample size that these tables usually represent. They're not meant to represent really high participant sizes, which can also lead to some statistical tests that are less accurate. And then finally, it is important to remember that 2x2 tables show association, not causation between two variables. So it cannot prove that one variable causes another. So to conclude, just some key takeaways of the risks and interpreting a 2x2 table is they are very simple and effective way to compare two variables and evaluate diagnostic tests. They're very easy to interpret, but they can sometimes oversimplify complex data. So it's important to classify results correctly. When reading a 2x2 table, always identify what the rows and columns represent, understand what each cell means, and use the table to calculate measures like sensitivity and specificity. And lastly, just a very important note, it does not prove causation, so it cannot prove that one variable causes another. Thank you. That's my references, and if there are any questions.
Thank you for your presentation. Before we continue, are there any questions, or would Dr. Lopez like to add anything?
Are there any questions? Otherwise, great job there, Natalia. For our uses and purposes, obviously, we use the two variables, exposure and outcome per se, as someone alluded to before. Chris was saying, we could use concussion and then maybe position. Something simple of that nature, or the exposure and the disease outcome, or the concussion per se. Those are two simple variables that we could use in epidemiology per se to evaluate the 2x2 table.
Yeah, concussions are a very common use for 2x2 tables with like screening on the field versus testing after was something I found in the research.
Great. No, thank you very much.
Thank you.
Our third intern is Brendan, who will be presenting on bias types and research. Brendan, could you share a little bit about yourself and share your screen when you're ready?
Thank you, Sadat, for the introduction. Could everyone see my screen? So today I'll be presenting on bias types in research. So what are research biases? They are systematic errors that impact the reliability and validity of the results. And because these systematic errors impact the reliability, it causes often the researchers to draw inaccurate conclusions if the biases are not taken into account. Some of the types of biases are design biases, selection biases, measurement, analysis, and publication biases, as there are biases in each step of the research process. So the first bias that I will get into is the design bias. A design bias is when there's an incongruence between aims and methods that lead to a bias. So my example on the slide is that I have when someone's trying to understand weight loss programs and they're using multiple choice surveys. This would be a design bias, as using a multiple choice survey would not provide individuals' experience in why certain actions happen, such as why certain people dropped out of the weight loss program and how, in this case, a weight loss program affects their daily lives. Another part of the design bias is personal beliefs and assumptions may lead to, when designing the research, may also lead to a bias. My example on the slide is that when a researcher who is working in pharmaceuticals chooses to only ask questions that support the usefulness of a drug. This illustrates how the personal background of this person being in pharmaceuticals causes them to assume the usefulness of the drug already. And the diagram on the right illustrates the balance between using preconceptions and objective data. Preconceptions can be used to come up with a hypothesis, but the objective data has to be combined to come up with a conclusion. In addition to design bias, there's also selection biases. Some of them are recruitment biases, which is the intended population is unlikely to participate in the study. An example that I have is you're trying to study old adult health and you use a survey that's provided online. This would not be the best method because often the older generation are not as well equipped online, and this would lead to a lack of the intended population. In addition, there are inclusion bias. Participants are not included are not representative. Similar to the weight loss and exercise program, only using the results of those who complete the program. Often those who complete the program are the most fittest. And this often leads to those who dropped out of the program not being included and leading to this inclusion bias. In addition, there are a confounding bias, which is a third variable that affects both the exposure and the outcome. An example of this is comparing treatment outcomes for similar conditions between general and specialized centers. Specialized centers may find a higher mortality rates, but specialized centers often have patients that are referred to with higher risk factors and more care is needed. And this would be the confounding variable in this scenario. And there's also sampling bias, which happens more often in qualitative research, where the sample does not include a wide enough range. In this case, if you're trying to study the entire population, but you only decide to include female participants. There's also measurement and data collection biases. When measurement biases are using unreliable, inappropriate, and poorly calibrated equipment, such as if you're trying to measure weight using poorly calibrated scales. There's also recall bias, which is more for retrospective studies, which are looking on past outcomes. Participants may not remember and report events accurately due to it being in the past. An example is questionnaires about experience of pain in past injuries. Depending on how far ago the injury was, the person filling it out might not remember exactly how painful that moment was. There's also leading questions. The wording of the question often influences the person's response. In the example, there are, how much do you enjoy the customer service today? In this example, it specifically use enjoy, and it assumes that the person answering this has enjoyed this service, and it kind of leads them to answer in a more positive direction. In addition, there are analysis and reporting biases. Analysis is data is only presented that support their hypothesis. An example is reports only students who achieved higher grades during online learning, and leaving out those who had worse grades. Example illustrates how the researcher in this case is only including the positive results. And often this is because academic journals are found to have more likely to publish papers that are more positive and statistically significant results, which lead to researchers having analysis bias. And a way of mitigating this is through unbiased reports by both reporting the outcomes that support and negate the hypothesis and also stating whether it's statistically significant or not. And there's also publication biases. Publication biases is when journals and editors are the one choosing the papers that are being published. Some of the ones being like I said before, quantitative studies, where studies have significant findings. In this case, some journals may lean towards publishing those with significant findings more. And for qualitative research, non-publication might be due to a lack of descripting methodologies or the findings not being presented clearly enough. And to help mitigate this publication biases, there are ethic committees and guidelines to help reduce this bias, such as CONSORT, which is the Consolidated Standards of Reporting Trials, and these basically set guidelines for researchers when it comes to randomized trials. And the image on the right, it illustrates what low publication bias versus high publication bias. As you can see, for the low publication bias, it's much more symmetrical, and there are papers on both the negative side and on the positive side. While for high publication bias, we can see there's much more on the positive and significant side, and there's much less on the left-hand side, which is more negative results. So in conclusion, understanding bias types helps minimize bias during the research process and design of research. And biases exist in all designs, in all part of research, which is why it's important to include in the limitations and to be transparent with the reader when just talking about your biases, as this allows the reader to help to better interpret your findings and allow them to interpret for themselves whether to apply your findings. And these are my references. Thank you.
Thank you for sharing your work with us. We'll take a moment for questions. Dr. Lopez, any comments or feedback?
Yeah, I just put in the chat the actual article, Smith. I think we try to eliminate many of the biases, particularly when we even structure things out. I think we had a conversation earlier today where we doing a survey, you have to look at how you word a question. And I think we had discussion in the group about please make sure you look at how you word it. You don't want to lead the person taking the survey into an outcome that's going to be biased. Obviously, that's one example of how we try to eliminate that and how the questions are worded. Secondly, there's a reason why our system now has moved digitally to an online system. It's so this way we can avoid transcriptional bias, right? And we want to avoid the transcriptional aspects of that. So, obviously it's a concern in research, but we try to address them. Obviously, there was a great, the article you chose, Smith, is the newest one out and does a great job of summarizing, understanding sources of bias in research. Okay, it probably brought in all the newest articles. That's why I shared it with everyone as well. So thank you. Did a good job there.
All right. That'll conclude the 5th week of our RISE Institute and Rugby Research and Injury Prevention Group Analytics series. Thank you for everyone for joining us.